Good afternoon, everyone. It's Dr. Jean Fourie here, and today we are continuing our theme on inclusive education, and we are looking at physical impairments today. So when we look at inclusive education, we are looking at how do we include people and learners who have all sorts of different disabilities in our classrooms. I'd like to start by looking at the South African population. And if we look at the population, we see that there is a variety of different disabilities. And the current statistics that we have from the previous census, 2011, I think it was done, shows the prevalence rate of about 7.5% of the whole population as having some kind of disability. Sight disabilities are the most common at 32%, and physical disabilities about 30%, hearing problems 20%, and then we look at emotional disabilities, serious depressions, bipolar disorders, and so on at 16%, and intellectual disability at 12%, and communication disability at 7%. So these are the amount that make up that 7.5% of the population that has some kind of disability that is serious enough to warrant medical attention, and in our cases, educators serious enough to warrant educational attention. So when we look at school statistics, enrollment in special schools in this country, in South Africa, we have a variety of different special needs schools, and these schools cater for different kinds of disabilities, and the Department of Education keeps statistics and records of these number of learners in each of these different schools, and they know the difficulties that the children have, and they put these into figures. So we have attention. I'm going to read some of the names on the top to give you an idea of the kinds of difficulties that we keep statistics of. So attention deficit disorders, autistic spectrum disorders, behavioral problems, and then all sorts of cerebral palsy, deafness, blindness, children who are deaf and blind, epilepsy, hard of hearing, intellectual disabilities, multiple disabilities, partially sighted, physically disabled, severely, profoundly intellectually disabled, specific learning disorders. So these are the categories of disabilities that we keep statistics of. And in our schools, and if we look at that, the highest incidence of, or the most frequent disability that appears is intellectual disability, which has a range from mild to moderate and severe, and we'll speak about that in another lecture. Then specific learning disabilities, these are difficulties related very clearly to reading problems, severe difficulty in learning to read, severe difficulty with handwriting, severe difficulty with doing maths. And attention deficit disorders is also high. Lots of children are diagnosed annually with this difficulty. We then have deaf learners, cerebral palsy, blind learners, behavioral problems, and physically disabled learners. So you can see that we are very proactive as a country and our education department in trying to ensure that we are providing quality education and that we are accommodating all the learners with various disabilities and impairments and difficulties that they have. We also keep statistics on each province and on the enrollment of learners in our ordinary mainstream schools. And so we know that not all learners with some kind of a problem are in special needs schools. The inclusive education policy allows learners to stay in a mainstream school, provided they are given adequate, appropriate support in that school. So we keep statistics and records of the learners in our ordinary mainstream schools who have all these disabilities as well. And then when we look here, the incidence of SLD, specific learning disability, is the highest. And that's understandable because children with an SLD have an average normal cognition. They don't have any physical problems. They don't have any visual or sensory impairments or auditory problems. So they can quite easily be accommodated in mainstream schools. We also see a high incidence of children with mild intellectual disabilities. We know that the moderate and profound and severely intellectually disabled learners will be in special schools. We also have a high incidence of attention deficit disorder in mainstream schools and partially sighted learners. So these are the things, if you are teaching, you are probably going to come across learners who have specific problems, who are mildly intellectually disabled, who have attention deficits, and who have difficulties with sight, partially sighted and partially hearing difficulties. So it's important for us as educators to understand some of these difficulties. So I want to give you a little bit of statistics. These statistics come from the 2011 National Census, which is the last one that was done. The National Census is being updated in 2022 now, and we're hoping for those results to come out in 2023. So from that census, we know that approximately 5.8% of the children in the country, and at that stage there were 14 million children in the country. We know that approximately 5.8% of them between the ages of 5 and 18 years old had some kind of disability. Okay, so that equates to 500,000 children who need to have some special needs, some accommodation within our education system, either in special schools or ordinary schools. However, at that time, when we looked at the statistics of the number of children in ordinary schools and we added it to the number of children in special needs schools, we do not come to 500,000 children. And so therefore we knew at that stage that there were 260,000 disabled children who are not accounted for in the school system. They were not in ordinary schools or special schools. We have not been able to update these statistics because the next census is only due now, but we are assuming and we're hoping that this will be a better picture, that there will be more learners. But I have been chatting to people that I know who work in the district offices, and they are very concerned about the long waiting lists that the special schools have. There are 3 to 4 year waiting lists for children to get in sometimes, And we also know that there are a lot of children who, because of their disabilities being so severe, that they are not in the schooling system at all. So we will be interested to see what these statistics will look like in the next couple of years. So now I want to talk about physical impairments in particular. And we're starting with physical impairments because as we are working from Bronfenbrenner's ecosystemic perspective, where we are looking at the physical body of the child first, we are looking at our physical being within the nested systems of the family and the school and the community and the society in which we live. So we will start with the center circle, which is the individual. And physical impairments relate to any deformities of the skeletal, the muscular system, and these children usually have difficulties with moving and with walking around and things of that nature, physical difficulties. So many of these children will be in special schools that accommodate learners with physical disabilities, but we are also finding a lot of them in our mainstream schools. And particularly if cognitive functioning has not been impaired, if cognitive functioning is normal at normal levels, then the learners can easily be accommodated in a mainstream school, provided that the school gives adequate access with ramps and wheelchairs to all the school facilities. So if we have a look, I'm just going to give you some facts as we go. For instance, if the school is putting in a ramp in the school for wheelchairs to go up and down, there are particular gradients that the ramp should be. So it shouldn't be too steep. It needs to be gentle. Otherwise, it needs to be at the correct gradient. If it's too gentle, it gets very tiring for the person. And if it's too steep, it gets dangerous. So the gradient, there are statistics if anyone is involved with upgrading schools, that they follow the correct ways of putting in ramps and little places where wheelchairs can go up and down curbs and things like that. So when we speak about disabilities, we look at the different body parts and the areas where disabilities can occur. And when we speak about multiple disabilities, there's a combination of problems. So there could be physical, sensory, neurological, to do with brain functioning, or cognitive issues, or some chronic illnesses associated with it. So for example, a child with a physical disability might also have some comorbidity, such as diabetes or high blood pressure or kidney problems. And so that makes it a multiple disability. And often there are associated difficulties with organs that are not functioning if there is some congenital difficulty with the physical body. So this is an example of a spine deformity called spinal scoliosis, and it's an exaggerated curvature of the spine. The person will need serious operations in order to straighten it, but it is a lifelong condition and has all sorts of other difficulties associated with breathing and heart function and so on. And this little boy over here has a foot deformity. He was born with a club foot. So that means that the foot is pulled up into a little ball rather than being nice and flat and straight. There are multiple different causes of physical disabilities and a variety of different diseases and things that can, factors that can have an influence. We generally divide the causes or the etiology of a disorder or a problem into whether it is congenital. Congenital means that the difficulty arose during fetal development. So something in the development of the fetus has caused the difficulty. So congenital difficulties may be related to problems with the genetics, the genes that are inherited from the parents. So there could be difficulties here with stature or posture, some kind of problem with the genetic composition of the baby. And then there could also be other health-related difficulties that happened during pregnancy. So congenital is during the fetal development. For instance, if the mother contracted diseases such as German measles or rubella, these are well-known viral infections that cause difficulties during fetal development, such as visual problems for this little girl over here, difficulties with heart problems, and various other deformities and delays in motor development. Here is an example of a cleft palate. This is a condition that a baby can be born with. There is a really good organization in the country, I think they're called SMILE, that assists children who are born with this cleft palate. And what happens is that there's a big hole in the top of the palate where the nasal cavity is connected to the mouth cavity. And so food gets into the lungs easily and it's difficult to breathe. And it's relatively easily corrected with a plate across the palate and cosmetic surgery for the lips, so that can be the child can be assisted with those kinds of difficulties. Then the next category of physical disabilities is acquired causes. So congenital happens when the fetus is still developing in the mother's womb, and acquired is after birth. So something happens to the child during development which causes all sorts of difficulties. For instance, the viral infection of polio left many children with deformed legs because it causes difficulty. The polio virus destroys the nervous connection, the nerves that lead to the muscles, so the muscles don't get innervated and they don't get contracted, so they don't work, and then the legs don't develop properly. So here's an example of a child in one of our special needs schools who has a special brace and some crutches to assist her with deformities and difficulties with the legs. Okay, there are also various motor neuron diseases, such as muscular dystrophy, that can cause the muscles to atrophy and the nerves are not working properly. So the most famous person is Stephen Hawking, who was in a wheelchair for many years, but his brain was working fine, and very bright man. He's made huge contributions to science and to technology, and so he was communicating with his eyes with special visual technology on the computer and special speech synthesis. So acquired causes can also be from violence, child abuse, children being abused, hit over the head or physically damaged in some way, and car accidents. Children involved in car accidents is a very high incidence of physical disabilities, problems with damaging the spine and landing up being paralyzed. So the range of physical disabilities is from severe, very severe disability to a more mild form. For instance, a severe disability such as full paralysis, where the child cannot move arms or legs, so paralyzed from the neck down. Severe problems with arms or legs causing loss, complete loss, or amputation in some cases of the limb. And so these children will often require appropriate assistive devices such as wheelchairs, specialized wheelchairs, and appropriate schools where they can move around. And then mild forms of physical disabilities relate to serious clumsiness, uncoordinated movements, and often these are difficulties between muscles and nerves working together, and eyes and motor coordination and integration. So there are problems with the coordination of all of this. And there are minor deformities of legs and hands and the body. For instance, a clubbed foot, child born with a foot that is deformed. And there are also tremors where there is difficulty with the coordination, and the nerves are not working properly. Okay. So we think about physical disabilities as movement disabilities. The mobility is the problem. The mobility, the child loses the ability to run and walk and be independent in their in what they want to do every way. So it's generally the loss of independence and that inability to get yourself from place to place, and require specialized equipment such as walkers like this one. This walker helps this child to stabilize his moving. He's got uncoordinated problems with his legs. And we can have wheelchairs, crutches. We need to look in schools for ramps and handrails, and sometimes modified toilets in order to get wheelchairs into and out of them. And so buildings need to be built to be accessible with lifts and ramps. And this mobility is the issue usually with these children. So provided that the child has cognitive functioning and is emotionally resilient, they are able to fit into an inclusive mainstream ordinary classroom if the school has the appropriate facilities and accessibility for this particular difficulty that the child has. Then we also classify physical disabilities related to disabilities around use of the hands. And these are manual dexterity disabilities. So this disability affects the ability to write, to use your hand, or to use your arms. Now, some learners will have a total inability to use their hands, and so that is a severe form of this. But there are others, such as the little boy in this picture, who was born with a kind of a clubbed hand. So he's got a thumb and his fingers are kind of fused together. So he's got really just a pincer, a modified pincer grip. He's been able to figure out a way to hold a pencil, so he can be pretty independent with doing some of his writing. The child in this other picture here was born without any arms. So he has no arms at all. He has to use his mouth or his feet, and so he has to have much more specialized equipment to assist him with the daily functioning and with his educational tasks that he needs to do. So here is this little boy, was born with a thumb, and he's kind of got a pincer grip, so he's got specialized equipment. There are all sorts of adaptive devices that are available for learners with difficulties, and these are put in place in the schools. Occupational therapists who work in schools often assist learners with these. Fat pencils, different crayons, large lines, supports that keep down books and paper, various different frames, grabbers like this one over here, and reachers, things that assist children to extend arms and to hold onto things. And then adapted computers. So there's a lot of technology available to assist learners to access the information that they can with computers. So we support learners with physical disabilities depending on the unique and specific problems that the child presents with. For instance, as the child, when a child is a little baby and we know they have a physical disability, they will need a wheelchair that is designed for the size of the child. And as the child grows and becomes more of an adolescent, the wheelchair will need to be modified and bigger for the child's size. So equipment is modified, it is uniquely designed, and this is where the team of medical doctors, orthopedic specialists, and occupational therapists who assist the learners in order to put in place the most appropriate equipment for the child's difficulties. And just a tip, if ever you are teaching in a school for learners with physical disabilities, the equipment is generally very expensive, and it can be highly specialized, particularly if we're looking at motorized wheelchairs and so on. And so learners need to be taught to handle this with care, and other learners also to help and assist this. So our role as educators is to ensure that we understand something about the child's unique impairments. So we communicate with the child, we communicate with the parents a lot, we collaborate, we find out what their needs are, and we try and implement and assist as much as we can in our schools. We also collaborate with the specialists, and this is where the school-based support team is so important. The school-based support team is a group of teachers in each school who should be assisting learners who have special needs, and they can call on anybody who works outside of the school to assist, or we can get reports from those people via the parents, and they can give advice sometimes which is needed on how to help these learners in the schools. So we can look at pediatricians and occupational therapists. A lot of special needs schools have a team of OTs who are physically in the school. There sometimes is a physiotherapist there. Sometimes these schools have speech therapists and nurses and dietitians. And these are all people that assist in putting together the most appropriate individual education support plan, an IEP, to assist that particular learner. So as educators, one of the things that we would be doing is just observing every day, seeing how the child is doing. And if you see that a child is not doing well, their health is deteriorating, something has happened, is to inform somebody, inform the school nurse, and let somebody take a look at these children. For instance, we know that children who sit in wheelchairs a lot often develop bladder infections and kidney infections, and they get constipated a lot because they're not doing a lot of moving, and so there's often difficulties associated with that that needs to be monitored. One of our roles is also to look at the classroom environment and to see what needs to be changed in order for wheelchairs to be able to get into our classroom, or a child on crutches or on a walker. How should we change the positioning of the desks? Some children have modified desks that they need to sit at. What can we do in our classroom to make it the most appropriate environment for the child? Then, from a school perspective, when we look at special needs schools, they tend to be, if they've been built specifically for learners with physical disabilities, they will have ramps and proper toilets and catheterization stations and sports grounds and play areas that are accessible for learners in wheelchairs. But a lot of schools were not built with this accessibility in mind. And if schools are doing upgrades or thinking about doing any modifications, they might want to consider ensuring that the wheelchairs and trolleys can access most of the areas in the school. And we also need to look at the material, the teaching material, which is in the school, and is the material in range of the child? Can they get to it? Can they see it? Can they access it? What do we need to do to make it accessible for them? There's a wide variety of assistive devices, trays on wheelchairs, adjustable desks, cutout tables, book holders, things that turn pages, different kinds of writing tools, and all of these assistive devices need to be individualized for the needs of the child at that particular time. We can also look at adapting the curriculum, for instance, avoiding too much written work, giving them additional time, looking at what is the easiest way for this child to hold a pencil or to write, audio recording some responses, making larger places on worksheets if their handwriting is untidy, worksheets that allow for circling and pointing responses rather than too much written work if there are manual dexterity problems. We can adapt assessments, for instance, audio record tests. There can be assistant who reads the test. We can do power testing where time is unlimited for that child. Think about keeping the items short and make sure that they're very logical and that you are clearly testing what it is you want to test. We can also look at the playground areas and devise games where learners in wheelchairs and walkers can participate. And really important is to speak to children in disability and to speak about the children in a school in disability-friendly language. This is called person-first language. So we do not speak about the crippled child or wheelchair users. We speak about the child, and the focus is taken off the disability. So we will say it's Tabo in the wheelchair. And our aim is to keep the conversations about children as normal as possible and not to constantly have that label of the disability clouding our view of the person who is actually there, the child, the individual within the wheelchair. So we talk normally and allow our language to include them and to have these children part of the activities that are happening in the classroom. We also know that children with these kinds of disabilities often develop associated secondary emotional difficulties. There are often associated depressions, serious anxieties, concerns about their health, about what's going to happen to them, difficulties with medical doctors. Often these children have had so much exposure to hospitals and doctors and medicine and things that they can get a lot of phobias around that, and it can be very difficult for us to manage as teachers. We should also assist them to socialize with both able-bodied and other disabled children. And please stay as positive and as constructive as you can when you are dealing with any people with a disability. Don't take pity on the child because they are in an environment where that happens a lot, but be positive and show them how things can be done differently and assist when they ask, when they need assistance. Often they want to try and do as much as they possibly can on their own. And so we help them to have as much normality as is physically possible for that child. And keep their passion alive and help them to build up some kind of dreams. Often it's very, very depressing being in wheelchairs and having a physical disability. So thank you very much for listening to me this afternoon. There are some references that you can look at, and I have put a whole collection of things on the Blackboard content area.